Welcome, everyone. Thank you for coming. I think this is our fifth patient education series from the Women's Health and Wellness Institute. We have Dr. Marky Knox with us here tonight, which I'm very excited. I'll give you an introduction. And Dr. Hugh Park may be joining us. She got held up in the operating room, so we'll see how that goes. But I kind of wanted to give you a little overview of the Institute since we've been doing these, and I see a bunch of people who've been on here. So the Women's Health and Wellness Institute was started about 4 years ago. It encompasses all of the physicians at St. John's who touch women. So that's everybody. That's every one of your doctors. And our goal was to come together and figure out how we can better take care of patients, what resources we need, what other specialists we need. We've had amazing input from our physicians in all kinds of different steering committees around mental health, around integrative medicine, around survivorship. And one of our big points has been around pelvic health, whether that's incontinence or hormone balance, which we're going to talk about tonight. In a couple of weeks, we have a big campaign coming out. We're opening our center, which is a place where not all of our services are done, because as you know, your doctors are kind of all over the city. But our goal is to have a place where we can commune, where we can have patient-facing seminars like this, physician-facing seminars, all for education. I do want to just mention our first three, what we call patient pathways, and we have patient navigators for this. So these will be available by the beginning of May to anyone. So far, they've been available just for physician referrals, but one of our programs is fourth trimester, previously known as postpartum, and all of the things that go along with that. So that's finding lactation, mental health, pelvic floor physical therapy, acupuncture, and our navigator, Marissa Harris, is fantastic at helping you find those. The second patient pathway is survivorship, so that's after breast cancer, ovarian cancer, thyroid cancer, colorectal cancer, and helping your physicians, your surgeon and or your oncologist connect you with all of those resources that we need. And the third patient pathway, which is very relevant to tonight, is pelvic health. So one of the needs of our community was really pelvic floor physical therapy, urinary incontinence, which affects 50% of women over the age of 60. And a lot of this is tied to hormone health and balance, which I'm sure the reason that you're here is because you've heard different things from different people. And we're super lucky tonight to have Dr. Marky Knox, who has been an OBGYN at St. John's for 40 years. We're gonna go with 41. Anyway, a very well-respected member of our community, and she's really helped us focus on this hormone health and balance, which so many people struggle with, especially the contradictory messages that we get from some of our doctors. So there's been some big changes recently, and so Dr. Knox is going to give us an amazing kind of overview of where we came from, where we are now, and then we're going to open it up for questions, which I know you have. So please put them in the chat. I'm going to sit down. I'm going to be checking the chat, and once Dr. Knox is done, then we'll have a good question and answer session. So with that, let me introduce Dr. Marky Knox. It's a good thing we're skinny.
It is. Thank you, Tiffany. That was an amazing introduction. I hope I can live up to all of that. So my goal, mission, task for tonight is to walk you through our journey to where we are now in our understanding about hormone replacement. And this has been quite a journey. For one thing, we didn't really find a need for it or understand a need for it until it's been about 80 years. And of course, there have been many mistakes made along the way toward trying to understand how to safely and effectively administer hormone replacement. But from those mistakes, we've learned wonderful things about where we are now. And when you think about it, that's sort of the nature of evolution. mistakes are made. I mean, think about what happened to the dinosaurs, etc. So what I want to do is try to start at the beginning and quickly take you through to where we are now. You know, at the turn of the century in this country, and I'm not talking about the most recent turn, I'm talking about 1900 to 1800 to 1900, women didn't really survive much past menopause, and many didn't even make it to that point. So there was a long period of time where there was no need for estrogen replacement therapy. Women didn't experience what they do now as we have lengthened lifespans. And a lot of those women who went through menopause almost looked upon it as a celebration. It meant no more periods. It meant no more babies. For a few, it may have meant no more sex, either way. But since that time, we've added 30 years to women's lifespans, which means that for most of us, we're going to spend at least a third of our lives in menopause. And when that started happening, there became a real recognition of a need, as women lived longer past menopause, of a need to feel better. I don't think that the health benefits were as highly prized as a relief from some of the symptoms that women experience when they're menopausal. So in around 1942, the Canadians came up with a product called Premarin. Premarin was what we now call a conjugated estrogen. It was derived from the urine of pregnant mares. I will say that when the Canadians first came up with this concept, their plan was to extract the urine from, or extract the estrogen from the urine of pregnant women. Needless to say, that didn't go very well. So we're back to the horse. And that product was rapidly embraced. It was introduced in the US in 1942, and the usage of it went through the roof until 40 years later. And 40 years later, somebody actually did a study and discovered that the rate of endometrial cancer in women taking hormone replacement therapy, Premarin, was rapidly escalating. And I think it's important to understand how that particular mistake was made. The decision about using estrogen was the thought that that was the most important hormone and the others didn't matter. But when you think about how your own ovary works, at the end of a period, your ovary begins to make estrogen in escalating quantities until mid-cycle. And at mid-cycle, women ovulate. So the job of the estrogen on that uphill side is to stimulate growth in the uterine lining in preparation for a pregnancy. With ovulation, estrogen plateaus, progesterone production begins, and the job of progesterone is to block that growth effect and prepare the lining to receive a pregnancy. If that doesn't happen, the whole process starts over again, and there you go. So progesterone was promptly added to the regimen of Premarin, and in fact there was a drug called Prempro, which was Premarin and progesterone in one pill. That was immediately added on. In 1993, the first really major study of hormone replacement began. This was what I'm sure you've all heard of, the WHI. And there were 3 arms in that study. One was the estrogen-progesterone arm, and that was for women who had a uterus. The second arm was estrogen only for women who'd had hysterectomies. And the third arm was the placebo arm, which was a complete failure because it's hard to fool somebody into thinking that the pill they're taking is estrogen if it isn't. They still had hot flashes, etc. But in 2002, that study was halted. The reason being they were seeing an increase in breast cancer, they were seeing an increase in heart attack, in strokes, and in thromboembolic events. So why was that mistake made? First, with respect to breast cancer, the decision made by the study administrators was that they would give the estrogen and progesterone in the way that nature or God had done it forever, which was to give 25 days of estrogen, 10 days of progesterone, and 5 days of nothing. And this, of course, caused women to have cycles. They didn't necessarily believe that they were still cycling. we've known for a long time that number of cycles contributes to the increased risk of breast cancer. So a woman starts menstruating early, ends late, has a higher risk than a woman who starts late and ends early. Pregnancy lowers your risk. Multiple pregnancies really lower your risk. Pregnancies with breastfeeding lower your risk as well. Why? Fewer cycles. So that immediately was recognized as needing to change. With respect to heart disease, the decision was made by the WHI preparation people that they would not start a woman on hormone replacement until she was at least 10 years postmenopause. What we now know is that, first, women are going to make plaque dependent on genetics, lifestyle, etc. Taking or not taking estrogen has nothing to do with it, but it does have to do with the kind of plaque that you make. One of the things estrogen does is lower levels of vascular inflammation. So if you're making plaque and you're making plaque postmenopausally and you're not on estrogen, you have higher levels of vascular inflammation, and the plaque that you make is far more dangerous, bulkier, less loosely attached, far more likely to break off and block an artery. And if you're on estrogen, then the plaque that you make, and you may make it, but it will be flatter, firmer, more firmly attached, far less likely to cause a problem. So what happened with the WHI, 10 years of these women having an opportunity to make plaque, they started them on estrogen, they dropped the levels of inflammation. Many of these women promptly had heart attacks, and that led to another effort to suspend the study. So this is, and we'll come back to that mistake because it's been made in some ways again. What it's done for me is that if I now see a woman who's more than, say, 5 years postmenopause, I will not start her on hormone replacement without doing a coronary calcium scan. That way I know if she has plaque. If she has too much plaque, then I know that that is not a safe option for her. The other thing that estrogen does is raise levels of HDL, which is the good guy cholesterol, not the bad guy. So that does help offer some protection. With respect to strokes and thromboembolic events, we know that synthetic estrogen, especially given orally, will impact clotting factors like factor V Leiden, like protein S deficiency, things like that, will make you more likely to have one of these events if you take them orally. I have to say that now that we use them transdermally, I have many patients who carry one of these clotting factor mutations that puts them at risk, and they're perfectly fine. Like anyone with these risks, when they fly or are going to be sedentary for long periods of time, they have to use some sort of an anticoagulant, like Lovenox or something of that sort. So what are the benefits then of figuring all this out and starting women on hormone replacement? First, you lower your risk for heart attack. That's a good thing. But more distant from that is one of the major benefits is prevention of osteoporosis. We know that all estrogen-deficient women will lose bone. Now, not all of them will ever lose enough bone to have a fracture. Again, depends on genetics, lifestyle, etc. But we've figured out now that what happens is your body requires calcium for a number of metabolic exercises, if you will. And its first source is the bone. So calcium is taken out of the bone, used for whatever purpose is needed. And with estrogen present, dietary calcium is replaced in the bone. So it's a constant turnover or remodeling of the bone, which I'm sure you've all heard of. But we also know that starting estrogen will not replace bone that is lost. So now, if we start a woman on estrogen early, we stop the bone loss. And by the way, the most rapid rate of bone loss occurs in the first year of menopause. So I still find people who feel like they should wait until they're sure that somebody is in menopause before starting. There's no harm in starting somebody perimenopausal on estrogen, especially if they're a skinny white chick or somebody who's, at risk for bone loss. The other factor about this is when we look at women who have osteoporosis, who suffer an osteoporotic fracture in their mid-70s. Only 30% of them are going to survive another year. So this is a life-threatening issue that can easily be prevented. The next benefit is protection against end organ complications of type 2 diabetes, which is sort of a newly realized benefit of hormone replacement. It turns out that, first, again, you'll get type 2 diabetes based on primarily genetics, also lifestyle. Estrogen will not keep you from getting it, but what it will protect you from are the end organ complications. And the way that works is that all your glucose is dietary or intravenous, depending on. But in the presence of estrogen, that glucose is transferred out of the blood vessels by the endothelial cells, which are estrogen dependent, into the muscle, where 80% of that glucose will be metabolized, keeping your blood sugar low. You take away the estrogen, the endothelial cells cannot make that transfer, and your blood sugar runs higher. And therefore, you are more subject to the end organ complications of type 2 diabetes. We used to say that estrogen did not do anything to reduce hemoglobin A1C, but we know now that that's not true, that actually it can slowly begin to lower hemoglobin H1C so that, I don't know how that affects risk, but it is a significant new realization. The next benefit is protection against colon cancer. And we know that this is only true for distal malignancies, doesn't have anything to do with proximal colon disease. But this has been shown to reduce your risk of distal colon cancers by as much as 85%. And that's huge, because colon cancer is, one of the things that we do worry about. And this is accomplished by estrogen's effect on ER beta expression in colonocytes. I have no idea what that means. I'm not a bowel person, but that's what it does. And lastly, of course, it is protective against memory loss. And we know that aging is associated with some memory loss. I know that because I have at least 20 pairs of glasses all over the house. But we know that the memory loss is accelerated in the absence of estrogen. We also know that it's not only more accelerated, but more extreme. We used to think that estrogen didn't help with Alzheimer's, and now what we're coming to realize with some of the ongoing studies is that it actually does. It doesn't eliminate it, but it slows the progression and delays the onset. So it is of actually some benefit with respect to that. I think, though, the important thing to realize is if we're talking about extending women's lifespans, it's not fun if you don't have quality of life. And yes, you get all these medical benefits, and now the way that we administer it, both transdermally and with bioidentical products, it's safe to take. But the important thing to me is the number of women that I used to see and still do see who come in on antidepressants because their caregivers are afraid to give them hormone replacement. And the antidepressants don't cut it. They're still anxious, they're still depressed, they lose sort of their sense of self, their self-image, they think they look old. When you're on estrogen, you do look old, but you may not think so, and that's a big improvement. They sleep better, and antidepressants don't cut it. So with all the fears that we've had about hormone replacement, if nothing else, please take away that we now have a safe, effective way to use it that leads to zero downside risk and, in fact, to some benefit. So, thank you.
That was amazing. Please, you can either raise your hand if you want to ask the question, or you can type it into the chat. I did get one question about, the WHI study, is this reversal a reinterpretation of the same data, or it's a new study?
It's both.
Okay, can you do that one more time?
Yeah, they've launched, the original study was terribly flawed, and they went back and obviously corrected, as they learned what to correct, the things that they were doing. And those have been separated when they present the data. So in other words, the period of time up until 1993 when the first stoppage occurred. That's presented as separate data from what proceeded after that, and then 2002 separate data. So it's the same people, but it's
The same people that they've followed over this whole length of time?
No,
No.
it's not. No, it's not. No, they would all be dead by now.
Okay.
Yeah.
And then there was another question about, sorry, you guys, I'm just checking my phone. So the conjugated hormones, which is what we got in the beginning,
Right.
versus the bioidenticals that we get now.
Right.
Can you do that in like a layman's terms?
Synthetic, basically. It's not identical to the estrogen that your ovary makes. That's what the term bioidentical means, is that you cannot, from a molecular perspective, discriminate the bioidentical estrogen that we use from the estrogen that your ovary makes.
And the original estrogen that we were giving was from horses,
Which is not bioidentical to ours.
which is not bioidentical to ours. Okay. That was one question. And then
And it was given orally.
So in the beginning, it was endometrial cancer
Yes,
that was caused by the estrogen.
correct.
And then all of the, I mean, obviously I'm a breast cancer surgeon, and so that's what I always hear is the breast
Right.
cancer risk. When did that come into play?
That was not recognized until that period of time between 1993 and 2002.
Okay.
But that's when they had added progesterone to the mix, because the first mistake was giving unopposed estrogen to women with a uterus, so they saw this huge surge in endometrial cancer. They had not used progesterone prior to that time.
Okay.
And so they suddenly went, okay, we got to use progesterone, but we're going to give it the way God did, so we're going to have cycles. And the women who don't have a uterus don't have to take it, so they were taking continuous estrogen.
And then, so there's still some people out here whose oncologist or their primary care doctor or even their gynecologist is still saying, no, let's wait.
Right.
How do we deal with that?
Education, I hope. I mean, it is becoming, I'm finding more and more physicians now aware of the safety of what we're doing now, and some even aware of the benefit. But I think the problem is, most of us, except for our specialties, practice what we learned as residents.
Yeah.
You don't find...
The things that aren't in your everyday that you're learning about all the time.
The things that you're not having to do every day, you don't go to seminars about, you don't follow. And I have followed this passionately over years. And, starting about probably 12 or 13 years ago was the first time I ever went to a conference where somebody said, get over it, this is safe, here's the way we're going to do it. And unfortunately, that word does not get out.
It doesn't.
Yeah.
Okay, here's another question. I'm almost 50. Oh, okay, I'm going to just do this one. I skipped the first one. We'll go back.
Okay.
I'm almost 50 and on PO estrase Provera, which is a mix of estrogen and progesterone, right? For 5 months.
Yeah.
I feel less dead inside, but also continued dyspareunia, which for those of you who don't know is pain with sex, which is when the tissues dry up. Using topical estrogen, zero libido. Can you speak to PO versus transdermal and the role for testosterone?
Okay.
It's a loaded question, but there's a lot of good info here.
Okay, let me see if I can remember all.
Go ahead, I'll prompt you.
First, Provera, do not take Provera. Take micronized progesterone. Excuse me. Provera is a synthetic progestogen and has a number of not deadly but unfortunate impacts on other parts of your body. So now we no longer use that. We use the micronized progesterone, which is bioidentical. It's a very delicate molecule. We haven't found a way to get it across the skin, so it is a pill, but there's zero downside to taking that orally.
And the micronized means that it's smaller particles, so it's absorbed
that it's
slower?
the normal progesterone molecule that your body made, but ground up in such a way that you can absorb it. Estrase is not, it depends. One thing, it's oral. You shouldn't be taking oral estrogens. Estrase is I believe, bioidentical with one little additive that they put in it, and I don't recall now what that is. I'm not sure that that's dangerous to you, but I think that the bioidentical transdermal products are much better, and we have a variety of dosages available for them that can be addressed. The vaginal dryness is sort of a separate issue. Those of us who are thin-skinned, fair-complected, are much more prone to that than people thicker-skinned, darker-skinned. But the bottom line is that your vagina is kind of a pig for estrogen, and what we give for replacement works for everything else, but the vagina is not happy. So we will often add vaginal supplements that are vaginal only. In other words, they don't add to your systemic dose. There's no risk in using them, but they do help to keep that tissue better lubricated, more distensible. One of the things you lose is elasticity, which is very unpleasant. And so there are solutions for that.
And the forms that come in are like a little suppository pill, what else, or a cream?
Creams, pills. The creams are great, except that if you use too much, they add to your systemic dose. Is that a problem? I don't know. It depends on what your dose is. Probably not for most people. But they definitely, the advantage of the creams is that they get onto the vaginal opening. And a lot of women complain about the vagina being okay, but the opening is painful. And that's because the pellets don't get there. So if I have somebody using pellets who doesn't want to use cream vaginally, I give her the cream and say, put a blob on your finger and rub it around the opening, and that helps.
That helps.
Yeah.
Can you talk about the difference between taking a pill every day and the transdermal patch? Because I heard you speak about this, I think, last month, and I didn't know that difference and how important it is.
That's very important. It's critical. There are pills. We no longer endorse them for all the reasons that I listed about their impact on clotting factors, etc., heart attack, blah, blah, blah. But the thing about the transdermal products, they come in patches, which normally are changed twice a week. You can swim with them on, you can shower, you can bathe, you can't scrub them, they'll come off. There are gels, which for people who can't remember the twice a week thing, the gels are great. I think the gels are also, now that they make them in individual packages, easy to travel with. They used to come in a big jug, now they don't. But they're both the same. They're going to get you the same result. There is a marvelous product called a femring, which is a ring, yay big, that you insert vaginally. You don't feel it. Your partner won't feel it. Seats around the cervix. It secretes a bioidentical estrogen for 3 months that you absorb vaginally, so you don't have to use any of those other products. Back in the day, it cost $150. Now it's $900.
Oh.
The business.
And I'm assuming that insurance covers some of these things and not others, because they're going to cover
That's correct.
the cheaper one. Okay.
That's correct.
All right, here's our next one. I'm 61, have been on hormone replacement therapy for almost 7 years. My new OBGYN told me to get off of them because she claims the studies have only been on women taking them for 5 years, which surprised me because I thought the new thinking was to stay on longer.
Yes. The new thinking is you stay on it until you drop.
So you stay on it until you drop, but there's a time period when if you haven't taken it, it's too late, or what's that?
Yeah, that has to do with the issue of plaque. So if I see a woman who's more than 5 years postmenopause and has not taken hormones, then I want to look at her heart. If she doesn't have plaque, she can safely start it. She has no downside to starting it, other than she's probably already lost some bone and maybe had some other issues, but she can safely begin it. There is no reason to discontinue it early. There's no stopping point. If I see somebody who has plaque, then it becomes a conversation about risk, which I tell them, it's possible that if we start you on this, you could dislodge plaque and you could have a heart attack and die. And I've had patients say, never mind, I'll take the chance because they're so miserable. And fortunately, all of them are still around. So
This is plaque in the carotids?
Yes.
So you could get a carotid endarterectomy, get some of that plaque taken out.
You could, yeah.
Okay.
And if you did that, then you'd probably be okay to go.
So the last question in that comment was, when is one supposed to go off of hormone replacement therapy? And I guess the answer is like never. There's just not
Never.
really a reason.
Never. There's no reason for you to stop. I have some very elderly patients who just can't get it together to use it anymore, and these are women in their 90s, and that's okay. But there's no reason, medical reason, for you ever to stop once you start.
Okay, here's the next one. I'm in perimenopause. So perimenopause, can you just define that?
It means you kind of ovulate every now and then, and your ovaries still gasping out a little bit of estrogen, but not consistent, not the way it used to be. And so you'll have times when it's your ovaries like, and times when it's like, doing its thing.
And is that a lab value, or that's when you're bleeding?
It's some women bleed, some women don't.
Okay.
It's a judgment call. Somebody comes
And it can
in
be
and
1 year, or it can be 10 years?
No, it can't be 10 years. It's usually, for some women, they have normal periods and then stop. And other women have normal periods and then they'll skip a month or 2 months and then they'll start again.
And that's
So
the perimenopause.
that's perimenopause,
Okay.
yeah.
Okay, I'm in perimenopause taking progesterone to treat PMDD. What is that?
Dysphoric, I can't remember it's bad mood.
Okay.
Yeah.
I'm taking supplements to address symptoms such as night sweats. Would you recommend bioidentical estrogen to treat those symptoms?
Yes.
Or is it recommended to start estrogen replacement later?
No.
Don't wait.
Don't wait.
This
Start
is-
it
this
as soon
is
as
our
possible.
message.
Yeah, absolutely as soon as possible.
Okay. And so is progesterone a normal treatment for mood disorder?
No.
No. Okay. But as you said,
quite the opposite, actually.
Yeah.
For some women, it's really, unpleasant to take.
what alternatives do breast cancer survivors have with respect to HRT, or is it not recommended?
Good question. At this time, it is not recommended. And let me explain that a little bit. The diagnosis of breast cancer in women is either you're hormone receptor positive, meaning estrogen, or you're not. The hormone negative breast cancers are far more aggressive and more dangerous and more difficult for us to treat. The estrogen receptor positive tumors, the theory has always been that they got there because estrogen made them go there. I think what we're starting to understand is that they got estrogen receptors just because they grew where estrogen was. That isn't what made them grow. It's the environment that they were in. And so the current thinking has been, once you treat somebody with estrogen receptor positive breast cancer, they cannot go back on estrogen again. There are now a couple of studies in progress where they're going back and saying, I don't think so. Let's start and see what happens. Too soon to tell. But it'll be interesting to see what we learn from that.
So either with, say, an endometrial cancer or a breast cancer where you're on hormone blockers, that's when you can't obviously take a hormone supplement.
There'd be, yeah,
Okay.
yeah. Those two wouldn't go together.
All right. How do you feel about brand versus generic versions of the transdermal patch?
I think the generic versions of the patch now have gotten so much better. They're small, like the brand names. The adhesives may vary a little bit, but the product doesn't. They're very good quality for the most part.
Okay. Next one. I have been on a progesterone-only birth control pill for 7 years. Progesterone only. Okay. Mm-hmm. You'll have to explain why you would be on a progesterone only. Should I switch and get on the combined pill, or is one pill better, safer than the other?
Are you menopausal?
I don't know. Are you on birth control pill for
birth control?
For birth control, or because you're perimenopausal or menopausal? Oh, because it's just progesterone, so that makes you think that it's...
No, some women do take progesterone-only pills for birth control, and they work. I have a lot of patients who find them to be unpleasant to be on. If you're not bothered by it, it's fine. It's not that you're being blocked from making estrogen. So if you're premenopausal, you're still getting the benefits of estrogen you're just not at risk to get pregnant. So I think it's safe for you to take that unless you don't feel well on it. And if you don't, you should take a combination pill.
Okay. Is there one that's less aggressive on the body, meaning progesterone only or the combined? And I'm not sure what aggressive on the body would mean. What would that mean?
It's not going to have a medical effect on you unless the primary difference that people experience with different pills is how they feel. And if you feel good on it, there's no risk to taking it. I personally prefer to see my patients on a combination pill strictly for comfort. So,
is there a role for testosterone in the realm of hormone replacement therapy?
It's a very good question, and I wish we knew more about it. What we do know is that in a woman who has her ovaries, if we give her estrogen replacement, even though her ovaries are no longer making estrogen, they will still play a role in processing some of that estrogen into testosterone. So people are not completely testosterone deficient. In women who don't have ovaries, they're not making any testosterone. The problem with using testosterone, and we have bioidentical testosterone available for use, in a woman who carries the gene for male pattern baldness, it can be a disaster. And I've had patients come in screaming with handfuls of hair, which is not good. But I think for some women, it's essential to their sense of well-being. Most of my patients are not on testosterone, but I have a few that are and that really notice that makes them happier. So
I still have another couple of questions, but I know that your practice is now more into hormone health, hormone balance. Are you now communicating with someone's team of physicians and doing some of that education, or do you mostly educate the patient and have them go back to their team? How is that working?
I try to reach out.
Okay.
And it's really hard when you're reaching out to somebody that you don't have a relationship with. So that's been more difficult. But I think part of our job is to get the word out.
Yeah, which is why in addition to these kind of seminars, we're also having patient-facing seminars. And actually at a talk that Dr. Knox gave at a hospital retreat, we had a very robust discussion between all the different specialties because there is still a lot of confusion around it.
Yes.
For people who this isn't what they're living and breathing every day and keeping up with their research.
Yeah, and I get it. I mean, I don't know anything about colons, so, I don't even know what those beta receptor things are.
Oh, you did know the distal versus proximal, which, by the way, just for those of you, so the distal colon is the last part.
Right, descending colon.
The descending, the sigmoid, the rectum, not anal cancer, right? Just into...
No, anal cancer is primarily HPV.
Okay.
Yeah.
And so then the other cancers are up in the higher part. Okay, how about using estrogen cream to help with vaginal irritation caused by estrogen blockers post-estrogen positive breast cancer?
I would be in favor of that. I doubt that the breast surgeon would like that. But if you're on the blocker, it's not going to get to your boobs. So, I
feel like there are definitely some of my, the oncologists for my patients who are fine with topical estrogen.
Yeah.
Right? And that's what this is talking about.
Yes.
The estrogen cream. Have there been any studies on whether or not that actually penetrates? No.
It's mostly a dosage dependent thing. If they're using, like the manufacturers of the estrogen cream recommend that you use 1 gram, that's a lot. And you don't need that much to get the benefit.
Okay.
You just need it.
And does it build up the tissue as opposed to just lube? The estrogen cream is actually building it up over time.
It actually builds up the epithelium over time.
So when you recommend it to people, do you recommend they do a little bit every day?
I find that that's hard for people to do. I have them start out doing a little bit every day for 2 weeks, and then I have them do it 2 or 3 times a week.
Okay.
And it works.
Okay. Keep them coming, you guys. We still have 15 minutes. Okay, I'm 62. I had a blood clot 11 years ago due to BCP.
Mm-hmm.
I have been told I should not do HRT, but can do topical.
Yes. You can do transdermal estrogen, and progesterone was not responsible for your clot. But you're like a lot of my patients who have clotting disorders, and as long as we keep you on the transdermal products, you're fine. It's only if you take it orally.
Okay, and that so to recap, estrogen is good for the brain. It's good for the skin and the tissues.
Yes.
It's good for the bones.
Good for your bones.
Good for your mood. Good for your colon, distal colon.
Blood sugar.
Blood sugar, I didn't know that one. So
And
that's
actually,
interesting.
the ongoing study right now that's looking at continuous bioidentical hormones, both combination and estrogen only, actually shows a slight decrease in risk of breast cancer.
Interesting. Why would that be? Do you know? Have they?
No cycling, I guess. I don't know. I'll be interested to see when it's done.
Okay.
But yeah.
And if you're ER, so estrogen, progesterone negative in your breast cancer, can you do hormone replacement?
I think you can,
Okay.
but I don't
Are you
know.
the minority?
Yes.
Look, you guys,
Definitely.
these are all tough, and this is the art of medicine, which Dr.
It
Knox
is indeed.
tackles so beautifully, because there's so many different questions around it. For those of you who want to share this, we have an amazing person who's helping us put these onto our YouTube channels, and so they'll be edited and you can share them. But there is one on sexual wellness. There was another one that was on hormone balance with a little different take on it.
Emphasis.
Yeah. There's one on bone density. So we definitely have some up. Courtney, will you hand me that flyer so I can say what the next one is? Courtney is one of our amazing patient navigators in the pelvic health program. Oh, so our next one is June 24th. Do I need to live with incontinence? And we'll have several people speaking around that, including our pelvic floor physical therapists, urogyne. So that will be a great one. Let me just do, I think there's one more question that came in. What are the ranges of transdermal estrogen doses, and how often do you suggest adjusting a dose?
The ranges run from, in most products, I mean, we can custom make them through a compounding pharmacy, but the pharmaceutical products that are available go from 0.025 picograms per milliliter or something like that, up to 1.5. Most of them are in the range of 0.25 to 0.1. The need, what we're shooting for with hormone replacement is an estrogen ranging anywhere from about 30 to 80. Now keep in mind your own ovary makes way more than that at the peak of its production mid-cycle. But we know that in that range you are getting all of the medical benefits that we want you to get. You may not get all the mental, etc., so we'll adjust as need be. But I usually start somebody on a 0.05 because I find that about 70% of my patients are therapeutic on that level and comfortable on that level, but not everybody. And so I test 6 weeks in and see where the level is, talk to the patient, see how you feel. We go up or down depending on what's going on.
So that was the second part of the question, is how long you know before the effect will be, and then is there something that you know if it's too high of a dose that would make you back off?
Sometimes breast tenderness will be a result. If it's really high, then the progesterone that we're giving you may not override the effect of estrogen on the lining, so bleeding can be an issue too. And of course we take that very seriously because we want to know what's going on. But yeah, I don't see that very often though.
That's amazing.
Yeah.
Okay, so in the chat, you guys will see that Courtney corrected me, which is great. Oh, it was just to me, sorry. So the next, apparently I missed the month of May. So May is actual sexual wellness, pain to pleasure. So we have a couple of specialists around sexual wellness, including, so not just on the female side, but also about erectile dysfunction, because that also affects women's sexual wellness. So that will be May 21st. Thank you for that, Courtney. And then we'll have the June one. Any last questions? Otherwise, we will end. And I really want to. And Courtney just posted in the chat the schedule, the upcoming schedule for that. Thank you for doing that. Dr. Knox, that was amazing.
Thank you.
You are a wealth of knowledge. I learned some stuff. I hope you all did too. And we hope to see you on May 21st. I had to pick it up. It was a little far away. All right, you guys. Thank you so much.
Thank you.
Have a great night.